Qualified, professional, and compassionate doctors talking real solutions to real health problems.
Good evening. It is your award-winning show on health, the DocTalk show, and I'm your host, Dr. Jagenda Joseph Ogavu, your physician and nephrologist from North Park Specialist Hospital. We are glad that you're tuning in once again because you trust us to provide you very good information, relying on your health, information that you need as a parent, as a person, as a community. We value you and we always give you the best around. And this evening, you may have heard and seen with me that the Minister of Health has actually released a statement talking about polio. Now, I'm a practicing doctor, and trust me, I've not seen a case of polio for decades, both as a person, but also as a practitioner of health. Yet the Ministry of Health has come out with a statement saying that they have seen traces of polio, and this has concerned the community so much. And so we brought in the studio the Director General of Health Services of the Ministry of Health, Dr. Mwebesa Henry, on my extreme left, and he's come with Dr. Juwari Alfred, usual host of ours here, who is quite concerned about our health. Dr. Mwebesa Henry, you're the Director General of Health Services at the Ministry of Health, and you actually released a statement talking about seeing polio in Uganda, and if my memory serves me right, it is more than 2 decades since we last had a case of polio. What has happened?
Good evening, viewers. Thank you very much, our host. It is true we released a statement about a week ago confirming polio in this country. Like you said, indeed, the last case of wild polio we got in this country was around 1996.
I was in 1996. I was in primary 7.
Good.
That's a good time ago.
Yes, that's how long it has been. And you are now a physician.
Oh yeah.
So that's when we last identified a wild polio case in this country. Along the way, we had a few imported cases from outside, not indigenous. I think a case around 2006 and another imported case around 2009. But since then, we've not been having original cases within the country. So we've been monitoring through our systems, through our health facilities, for any cases of polio, and there was none through our routine measurement. So actually in 2010, we were declared to have eliminated polio out of the country. And following that, we continued to monitor, because much as we are declared to have eliminated the problem, you still need to continue to monitor to see that you don't get cases, to see that you don't have imported cases, you don't have original cases. From 2017, we actually started even monitoring the environment to see could there be any shedding of polio viruses within our environment. What I mean here is that we check, because polio is spread through the oral fecal route. So let's say you eat, you pass the oral polio virus into the stool. So normally the easiest way of us finding out or studying is through sewage plants.
I see.
So we started since 2017, we collect sewage from the sewage plants in Ruviji and in Bugorobi, the main sewage plant. Also in Entebbe, and in some districts in Fort Portal and Arua. And we test to see if there's anybody shedding the polio virus. And since 2017, we have not got any. But in July this year, we were able to identify some polio viruses in the sewage in Ruviji and in the sewage in the one we collect from Bugorobi. We haven't collected from any other plants yet or any other areas, but that was the source of concern. Because in a country, as long as we pick even one case, then that should be a source of concern. So that's why we said there is a problem of polio in this country, and hence the release of that statement.
So the ministry is concerned that what causes polio disease has been seen with us, even when we have not seen people that actually have polio as we know it.
Very true, Doctor.
So it means that at this time there's a lot that we can do, and I am sure that the ministry is actually gearing up to address this so that it doesn't become a big problem.
So what this means is that there is somebody shedding those viruses within the environment here in Kampala, especially those who are in the area which empties their sewage lines to Bugolobi and to Ruviji. We have done further analysis. We haven't yet picked any child or person that has, because we did also stool analysis of children. We've done that in Kawempe, we've done that in other surrounding areas to see if the children are directly having the virus in their stool, but we have not found that. But still, that doesn't give us comfort because we know there is somebody who is shedding it. And what this may mean, this could be visitors who are coming from the region, within the region, because we know that those cases have been identified in some of the regions or some of the countries within the region. So it is also possible that it could be a visitor who is, or visitors who are within Kampala, who are shedding the virus into our environment. And of course, we'll be discussing how that can be dangerous to us as a country.
And in fact, Uganda last recorded this indigenous case coming from one of us in 2006. That is a good number of years ago, about 16.
That's about 15 years?
Yes.
15 years ago.
And the last cases were actually imported. Because we cannot close ourselves out of the world, it happens that we are getting some people coming in with what we would not call indigenous, so the term imported. Okay, I admitted at the beginning of the show, Dr. Diwali, that I have actually not seen a case of polio arising. I've seen people that have effects of polio, but I have not seen them come to me and say this is polio. By the way it looks. What is polio, really?
Dr. Ogavo, the point, the fact that you have not been able to see is good news for us because polio used to be very rampant. So polio is a disease which is targeted for eradication. So all the efforts which Director General has explained are geared towards ensuring that no, the virus is not found circulating anywhere. So in our health facilities, routinely we check. And the stools of children who are suspected is checked. And we are also checking in the environment. So that's where we picked this. So it is important to note that the cases of polio are very rare, so new practitioners may not actually recognize it quickly. Polio is acquired by consuming food or water which contains the virus.
So polio is food and waterborne?
Is food and waterborne. So you acquire it through the mouth. Now, you pass it to the next person through the feces. Now, when the feces finds its way to food or water source, then the next person gets it. And you can see these viruses were actually found in sewage, which means putting us at risk. Now, once a child gets polio, there are many complaints which will come, and many of them will be vague. There is fever, there is body ache, there is stomach ache in the acute phase.
So these are common symptoms.
Common symptoms.
That could actually be malaria, it could
Yes.
be pneumonia, it could be
Yes.
diarrhea.
Yes.
Simple.
But eventually, you now start seeing that either the muscles become stiff or they become paralyzed. So now this is where, depending on where this muscle which is paralyzed is, if it is the diaphragm or the chest,
That is
it
the
could-
one that
for breathing.
stands for breathing.
So it could result into death.
Okay.
But often what we see is paralysis in the limbs, either the hands or the legs. And this is what we see. Now, the importance attached to eradication of polio is linked to its socio-economic impact. Physically, it challenges people, and it puts, it also has economic limitations for people who are affected. Most of them may not do what they would otherwise do. It affects their potential. So it is worth doing without this disease.
And I want to take you back a little. If it attacks other organs, you could actually die much faster
Yes.
than, say, if it attacks the limbs. So that means that it could actually be a silent killer. Because
Yes.
by the time you see the effects on the muscles, it has actually done some good
Damage.
It means that a good number of children may go through our hands and you don't notice it's actually
Yes.
polio. So thanks for actually being able to do the surveillance, because you're picking this before it is too late.
Yes.
My pride as a clinician is to be able to save life, but seeing someone that is coming in with the recognizable complications is actually very late for me and very saddening for a condition like this. Allow me to take this short break, and as you are taking the break, please join us on our Facebook and Twitter handles. We are live on YouTube, DocTalk Show. See you soon.
The Ministry of Health informs the general public that amidst the difficult times of the pandemic, routine immunization for all children under 5, those eligible for HPV vaccines, and women of childbearing age is still going on in all our health facilities. Parents and caregivers, take all your children for immunization as per their schedule. All vaccines are safe, effective, and free. Remember to observe the COVID-19 prevention measures as you go for immunization services. Wear a mask properly, covering your mouth and nose. Wash your hands regularly with soap and clean water, or use an alcohol-based sanitizer. Maintain a physical distance of at least 2 meters from others and avoid crowds. This message is from the Ministry of Health with support from partners.
You are watching the DocTalk Show.
buli munya-uganda nayetenga amakuru marungi. UBC West erina amakuru marungi kandi agali kwesigwa. Leero za puroguramu zaayo ziri omu Lunyakitara hamwe n'Orufumbira. UBC West erina tekinologiya ey'omulembe eri kugibaasisa kuhika omu bicweka byona omu ihanga nangu n'aheeru y'eihanga. Tukwatire aha frequencies ezi: Kisoro 97.7 Fama, Kabale 93.7 Fama, Hoima 99.1 Fama, Kampala 105.7 Fama, Mbarara 97.4 Fama, Footpoto 98.8 Fama, Masindi 5 Fama. Kurikiriza UBC West ohurire embaganiza. UBC West empika huna.
My home, I smile when I think of you, Uganda. My home. My home, I dance when I look at you, Uganda. My home, oh my Uganda.
I know with you I'll always
mojo.
At MTN, we look forward to starting another exciting journey together to grow our home, Uganda.
You are watching the DocTalk Show.
So Dr. Ajuade, before we actually went for the break, you told us about the fact that you've seen the virus, and it's mainly children actually that are affected. One wonders why children are the ones of concern, and how can this actually transform into disease? You've only seen a virus hiding somewhere.
Right.
The sewage, of what concern is it to me? I'm not about to go to to the sewer plant. I do not work there.
And swim there.
Yes. I'm really not connected to
Right.
it. How is it going to affect my child?
Right.
Yes.
So picking poliovirus from the environment from the sewage in this case is very important in a number of ways. Number one, it confirms to us that in the catchment area, which is drained by the sewage system, there are people in that area who are carrying the virus, and they are putting it out through their feces. And once they flush, it travels to the sewage plant.
And you can't tell where.
You cannot now
because
tell.
Kampala stretches from Namave
Yes.
up to
Up to-
Kawanda.
yes.
Yes.
Kawanda,
yes, Gayaza.
Gayaza,
Nama drain into the sewer line of Ogoroi.
yes.
So you.
So when you pick the virus from Bugolobi, what it means is all areas
Somewhere in a very big
in
expanse.
that big area which is draining into Bugolobi, somebody is shedding. So you do not know, you cannot know who or where this is.
And you can't go out testing everyone.
You can't go testing out. So what it means is that the people in Kampala area served by this sewage plant are shedding the virus, and they can potentially infect others. Now,
and these are well-to-do people.
that even makes
their story is
yes. If we
are
work,
connected to the sewage line.
Yeah,
if we
connect the
work,
sewage line.
if we work backwards, it could even be beyond the well-to-do, because Kampala is the business district. There are people who come to the city. They use the sewage system. If by extension, the people who are coming to the business area could be coming from the region or from all
anywhere
other
in the
parts of the
country.
country.
Nice.
So picking this virus in Kampala is very, very telling for us, and that's why we take it seriously, and we should be able to respond effectively. So children who, by the way, what they drink, by way of what they eat, and the fact that they may not follow our rules of wash your hands before, drink clean water, drink clean food, you will find that the possibility for these children to get infected is very high. The flies carry these to our food, so it may not be very intentional. So the risk of transmission of this disease is very high. And as DG had touched earlier, the analysis done on this virus actually pointed to us that this virus has been circulating around for about 2 years. So we chanced to pick it.
So it wasn't showing, but
It
your
wasn't.
studies have actually shown that it has been.
Yes, it has been around
Around.
for about 2 years. The experts can do that analysis.
And
that's
this
the
could have
feedback.
been my auntie or uncle from the village
Yes.
who came to visit me,
Yes.
or came for a party or something, came to trade,
Yes.
and then could have gone back. Or it is someone that is residing
Exactly.
in the
So
city.
that you are describing the complexity,
Those are possibilities.
the
Yes.
possibilities. So it is very complicated, and that's why in this kind of amorphous, in this kind of vague pointing of where the disease is coming from, at an individual level, the best you do is to ensure that your children are vaccinated and their vaccination status is up to date.
And DG, has vaccination helped us before? Is it what we should be doing?
Thank you very much once again, Doc. Certainly vaccination has helped us before. That's why we told you we were declared to have eliminated polio in 2010. That was mainly because of the vaccination. And it is for that reason that even now we want to intervene in that context. But before we get there, I want to emphasize that one of the major interventions is proper food and water hygiene.
The basics, back to the basics.
Back to the basics. So that we emphasize washing hands, we emphasize boiling water for drinking, because my colleague has emphasized that we get this infection through the oral route. What you eat and what you drink, if the virus is there, then it will get into our children. So the emphasis, and we shall continue sounding this very loud and clear, that with this threat around, we must emphasize proper food and hygiene. And then, but on top of that, we will supplement it with vaccination. And we are going to have a mass vaccination drive of polio, with polio, and that is oral polio vaccine, the novel virus. But I think for our people, what I need to emphasize is that we are going to use an oral polio vaccine.
It's not a jab.
It's not a jab.
You won't have to wrench when you're receiving the vaccine.
The children shouldn't get worried.
In fact, I've seen some ladies crying on behalf of their children when they are getting the jab.
So it will be an oral
be
vaccine. We estimate to vaccinate about 7.5 million children, and covering from 0 to 5 years. All under 5s will be vaccinated across the whole country, from Kisoro to Arua to Karamoja and down here. And that will be done during the months of October and November. And we should be able to do it within a week to cover the whole country, because the districts will be provided with vaccines, will be facilitated to make sure that we do it at our health facilities, and all mothers will be encouraged to bring children for vaccination so that we protect our children.
And I want to believe that we are well placed to actually handle this vaccination, because the last time we did measles and rubella, the response was actually overwhelming. And
we vaccinated
beyond our target.
19.4 million people. So with 7.5, we should be able to cover it very fast.
I see.
And the response from our mothers was very good at that time. We believe that the same will happen this time. They should be able to bring children for vaccination, including those who had already received vaccination for polio. This is a booster. They should come and have their children vaccinated.
I see. Great. Mothers, something is threatening the lives of our children. I'm calling on the fathers too, Dr. Duwali. It's not just the mothers that should be seen participating in saving the country from the threat of polio. So we have a chance to protect ourselves and our children and secure our future against polio. And we are glad that our ministry is well geared for this. We've actually had many successes in vaccination, and I want to believe that the whole ministry is actually ready to help us overcome this small challenge that we've seen early enough. We should be able to turn out victors. Where are we going to get this vaccination from? That's always the question. Should I wait at home? Shall I wait at school, or to be the health centers as we know them?
The design of this campaign will be to mobilize children through their mothers to move to designated vaccination points. And in other circumstances, we will also move from home to home, especially in the high density areas which are urban and where people's styles affects their access or participation in such exercises. We will be providing details of this exercise in due course through the district local governments, the district health offices, the sub-county authority, the village health teams, and LC1s will be the ones to mobilize for this exercise in the month of October and November. Vaccines which are used, the vaccine which is going to be used for this exercise has been assessed and it has been registered by WHO as a safe vaccine. And these are vaccines whose logistics will be managed by UNICEF. Is the case for vaccines which we use in this country.
And we are not trying out an experimental vaccine because the experiences with the other vaccines, people have had to ask questions whether they have actually undergone the regular stringent testing that they should do before they come to the human being.
Yes, these are vaccines which go through the conventional research and testing. That's where the safety profile is assessed. And actually, the vaccines which are going to be used from now on towards the elimination game are more stable than the ones which were before. So it confers more benefits to protect people than those other vaccines which were in use previously.
I want to thank you, Dr. Juwali, from the Ministry of Health, and our Director General of Health Services, Dr. Mwebesa Henry. So the ministry is rolling out vaccination come October and November, and mothers, fathers, everyone, let's get involved. We go for this short break as you follow us on our YouTube page, Facebook and Twitter, and we are seeing your questions coming in. I promise we shall answer them in the coming segments. See you soon.
You are watching the DocTalk Show.
Echa COVID-19 kijja kuggwa only if we stay at home, observe physical distancing, wear masks properly, sanitize or wash our hands with soap and water regularly, or get vaccinated now.
You are watching the DocTalk Show.
Welcome back from a break. Dr. Jagenda Joseph Ogavu, your host for the DocTalk Show. We are glad that you're still on. And with me in the studio is the Director General of Health Services, Dr. Mwebesa Henry, and Dr. Juwali Alfred, again from the Ministry of Health. Switching gears a little from polio vaccination back to COVID. We've had the challenge of polio, for which you have laid out a very good plan. We are going to encounter that, and I'm sure we shall succeed. But back to matters that are to do with COVID. Dr. Mwebesa, coming from the Ministry of Health, you know how Ugandans have been asking. We have our money. We've committed quite a big chunk of the budget to the purchase of vaccines. How far have we reached? Have we vaccinated any people? How are the figures, and where are we heading?
Thank you very much, Joseph. Those are really very, very important questions at this time. Let me first mention the numbers where we have reached so far. We have received over 1.3 million doses of vaccines, and we have vaccinated about 1.3 million people. Of those, about 900 have received the first dose, and the 900,000 received the first dose.
Yes.
353,000 have received the second dose, which means we have a population of about 600,000 who have received their first dose but are waiting for the second dose. Because that's a big gap that we need to address as soon as possible. And the challenge has been that we have not been having adequate vaccines. But I want to assure Ugandans that the future looks much brighter now.
I see.
We're expecting quite a number of doses of vaccines. We get our vaccines through 3 methods. There are donations that we get. Actually, all those 1.3 million doses, 1.327 million doses that we received were mainly donations through the COVAX facility and through friendly countries like India and China. And the second method is also purchase of vaccines through the COVAX facility and the African Union. And the third is where we get direct donations from friendly countries, as I said. So, as I said, the future looks much brighter than it was about a month ago. Because right now, as you saw in the press recently, we received a donation of AstraZeneca vaccines from UK, 300,000. That joined the 300,000 from China, which we had received about a week earlier. So now that shows we have 600,000 doses, which we are using currently. But September has even a brighter future for us. Within September alone of this year, we're expecting about 2.5 million doses of vaccines. We're expecting over 1.2 million doses from Pfizer. That's a donation from US government. We're also expecting Moderna, about 645,000 doses, also to come in September. I want to assure Ugandans here that before that we had a problem of how to store these vaccines because they require very cold temperatures, -70, -80. But the government has procured adequate storage capacity. We can even store up to 10 million doses of these very, very cold vaccines requiring very cold temperatures.
Very good news coming from you, Director General.
Thank you. We're also expecting about 600,000 doses of AstraZeneca. And that, I think, will bridge the gap of the other 600,000 I talked about.
Okay, that are yet to receive their second dose. I see.
So I think that one will come in time. But as I said, the government also has put in place a budget to purchase vaccines. And we are purchasing 9 million doses of Johnson & Johnson. This is a single dose. 9 million doses.
9 million.
Yes.
So straight away we shall vaccinate 9 million without the need for them to actually go for a second
dose.
I see. So that will give us some good mileage.
That will give us. But this one, we are buying it through the African Union. But it is coming in tranches. The initial tranche which is coming in may be not a lot. In September, which may come in to the tune of about 500,000 or so.
Okay.
But going forward, they'll be sending a little more, and this will spread up to June 2022.
I see.
But also, recently we received an offer through the COVAX facility again of a number of vaccines through Sinopharm vaccines. And we made a commitment to procure 18 million doses.
Okay.
But this one, you do dose 1 and dose 2. So that should cover 9 million people.
I see.
But the beauty about this is the vaccine from China. The beauty about this is that the supplies are available and they'll be able to provide it between now, September and December. So by December, they should be able to give us 18 million doses, which should cover 9 million population.
Wow,
I'm seeing
a mass and I'm smiling. The Ugandan out there has reason to rejoice. Our money is being put to good use, and I see 9 plus 9, that's 18 million. In a short time, we shall actually have crossed to half the population.
Yes,
so,
and you remember our target is 22 million.
I see.
So this gives us a mileage of already 18 million population.
So I see a lot of freedom come 2022.
Exactly.
I see. So in the meantime, you out there, keep sanitizing, keep that mask on, obey the curfew hours, and
so that the doses find you alive.
yes, the doses find you alive. That's very, very important. On that note, we are taking a short break, and we see you after.
Show profiles Uganda's healthcare sector.
On the DocTalk show today,
Like a first car on a mission, the Uganda National Health Laboratory Services is on a mission to provide accurate, reliable, and dependable diagnosis to disease prevention, management, and control. As the experts explain in the following expose.
Samples come in from all over the country, brought in by riders and drivers, and when the samples reach sample reception, our duty is supposed to be reception. However, when these samples come in, they are very many in number, so we cannot work on them at once. So these samples come in and they are stored in different kinds of ways. They are stored in fridges, others are stored at room temperature. But when the driver comes in the facility, his duty is to make sure that he registers in a delivery book that we have here for all different kinds of samples, because there are various samples that we receive here. For example, there is a COVID book, there is a viral load book which is for HIV, we have an EID book and other samples to make sure that actually these samples were delivered here. That is the way we can confirm and show evidence that the driver actually brought the samples here. The second thing is that the driver also tracks these samples, because there is a QR code right outside here that is supposed to also confirm within the system that actually these samples have been delivered, because you need to know that the actual presence of the driver was here. So when the samples are put in our fridges, our team of lab technologists comes in and receives these samples in different ways. We have samples that have to do with HIV. HIV comes packaged in two different ways. We have plasma and DBS. DBS is dry blood samples. Dry blood samples is kept at room temperature, but the plasma samples are kept between 2 to 8 degrees in the fridges that we have that enable us to do our work well. So when these samples come in, the ones of plasma, for example, that whatever is the patient ID is on the sample and it's again placed onto the form. So when someone is receiving, actually, his duty is to make sure that what is on the sample is on the form. That is a process of verification to make sure that what was sent from the facility is actually what we are receiving. Individual will make sure that these samples are received in what we refer to as boxes. Those are plasma samples, which makes it easy for us to track within the lab. Each of them is given a different locator ID, depending on which month we are in, depending on the day that we are on, the particular day we are on. For example, if today is the 2nd of August, the barcode will clearly show the year, the month that we are in, and the day. So, and the position and the box of that particular sample, so that even if someone got up in the morning and the sample, for example, fell off the rack, someone is able to identify where that sample belongs. That is for our purpose within this institution. By close of business, which is around 5 p.m., the total number of samples for plasma will be received and accessioned, and then will be ready for the lab, so the lab can come and pick them. The forms that we also look at and compare this information are also handed over to a different section called data, where we have the dry blood samples, because HIV, remember I told you, is packed in two different ways. The dry blood samples come in also at room temperature. They are packaged in they are packaged in a triple kind of format, in that there is no way that this sample will get contaminated. So, and the kind of packaging is polythene-like. So this sample is basically protected 3 times. So this sample is kept with its form in a Ziploc. In that Ziploc, when we receive these samples from the different facilities, the individual who is receiving them at a particular moment is supposed to open this Ziploc and make sure that what the sample has tallies with what the form actually has. And the way we do it here is that we pile ours in 2020, in batches of 20, which we refer to as envelopes. However, from the facility, a facility can send up to 100 depending on the number of patients they have, but we have a certain way we're supposed to repackage them to help our system that was built for this purpose to make sure that if the samples are received, they are easily and ably trackable in the institution. So these samples are open. These ones are not infectious as the earlier ones of plasma. These ones are quite different. They are dry. So you open the sample, you open the Ziploc, you have the sample and form until you have a pile of 20 and you tie them in, you close them up in that Ziploc and the 20 forms. The moment that is finished, we have a process whereby we refer to it as accessioning. Each of these samples is given a locator ID so that it can be easily tracked. In that, at any point, just like we did for plasma, we do the same for DBS, but the distinction is that the locator IDs differ in that one can look and say that this is for DBS, this is for plasma. When we finish receiving them, we place them on the side to prepare for approval. The forms are still taken to the data section for entry so that when they enter them, they can come back to us for approval. Before I go to the approval stage, we have other samples that have to do with EID and sickle cell. These samples are as well received through the same process. They come in as dry blood samples only. That is really a huge emphasis we also pass down to the facilities. The purpose of this is to ensure that these children are safe right from birth, and if they are not safe, how can they be protected? When it comes to DBS, the individual at approval stage, when the forms have come back from data, is supposed to have the samples with him or with samples with him or her, and ensure that, and the forms as well, and ensure that in the system what has been entered is exactly what is on form and is exactly what is on the sample. This is a very integral part of this process because it's at that point whereby if you send someone sample wrongly, you will have made a huge mistake. The moment that is done, samples are put back on the side as approved, because in the system they'll show they have been verified and checked. Then they are prepared, they are ready for the lab, the core lab, to test.
You are watching the DocTalk Show.
buli munya-uganda nayitinga amakuru marungi. UBC West eyina amakuru marungi kandi agali kwesigwa. Leero za puroguramu zaayo ziri omulunya kitara hamwe n'orufumbira. UBC West eyina tekinologiya ey'omulembe eri kugibaasisa kuhika omu bicweka byona omu ihanga nangu n'aheeru y'eihanga. Tukwatire aha frequencies Kisoro 97.7 Fama, Kalari 93.7 Fama, Hoima 99.1 Fama, Kampala 5.7 Fama, Mbarara 97.4 Fama, Futpoto 98.8 Fama, Masindi 5 Fama. Kurikiriza UBC West ohulire embaganiza. UBC West empika huna.
You are watching the DocTalk Show.
Vaccinated in a span of about a year. We really want to thank you, the Ministry of Health, for these achievements that we are definitely going to make. Now, Dr. Juwali, you're very much in charge of seeing how this vaccine gets from that cooler box into the arm and therefore protecting us. And we began by vaccinating health workers, those in security, and then we expanded to those that are having comorbidities, hypertension, diabetes, heart disease. Have these target groups changed or are they the same?
The target groups have generally remained the same. As you can see, that first group of vulnerable people to be vaccinated as a matter of urgency, the total number is about 5 million people. And the number of doses we have received so far has not enabled us to vaccinate that number the way we would want to do. Now, within this priority group of health workers, teachers, security forces, persons with the underlying health conditions, and persons above 50 years of age, there are those who who have already gotten these jabs, and new ones continue coming. But with the doses which the Director General talked about, we are going to be very clear on how we are going to deploy these vaccines. The AstraZeneca doses are going to be used for those who are due for second dose.
For the second, because that's what you've been getting.
Then this includes the ordinary person, and we are laying particular emphasis on teachers, because now we are fast tracking vaccination of teachers with the hope of accelerating opening of schools.
And that's a question that we parents have been asking.
Precisely. So teachers who are due for second dose for AstraZeneca should seize this opportunity, because by the end of next month, the plan is all teachers should be vaccinated. I will explain. And people who are older, who are in the priority group which I had outlined, can also get access. So therefore, nobody should be turned away if they are in that category to get their first dose. Now, to ensure that we close this vaccination activity on teachers, we have also had a very specific instruction to districts on vaccinating teachers using the Sinovac vaccines, which we have apparently set aside to achieve this objective. Now, in addition to the static, all the outreaches which are done for everybody with Sinovac, teachers have, our experience of today has been very, very encouraging. The teachers have organized themselves in schools. They have organized themselves in sub-counties, where all the teachers are coming in one place as a distinct group, and we are going to vaccinate them there.
And teachers have always been organized. I'm sure they are going to pull this one off.
We are very impressed. I wish this was at the beginning. So we are going to vaccinate the teachers with this vaccine. The advantage of Sinovac is the interval for the second dose is just 1 month. So teachers whom we are vaccinating at this point, towards the end of September, they will be due for their second dose, and that is the program. And we are working together with the Ministry of Health to ensure that this program succeeds in a record time, so that now Ministry of Education will start a different program of school opening. Now, the other special group at the moment we're focusing on, because of the limited doses of vaccines, are the students who are already in health training institutions.
So you're talking about the future doctors,
the future nurses, physiotherapists, and so on, because they are already in school setting. So vaccination of them, their vaccination, and potentially they're working in an infectious environment.
In fact, they are in contact with
yes, so they are like, their risk is as high as that for health workers.
Yes.
So for this reason, we have worked with the districts, the DEOs, and the health training institutions to ensure that the tutors who are not vaccinated, the students are vaccinated, so that they learn in a safer environment. And as more vaccines become available, we will be expanding this program to ensure that we can't keep our children at home for a very, very long time. And this is a program we will keep updating the public on. It is very important to respect this targeting, because the people we're targeting are at the highest risk of developing severe disease. They are the ones who are at the highest risk of being admitted, and they are the ones who will need more oxygen. And if we do not vaccinate this group as a matter of urgency, we are going to get congestion. Deaths will be a big issue. So we will encourage that let's target them and vaccinate them. As we program and plan to open schools, Remember, the parents must be protected, because when the children will go to school, they will not be there indefinitely.
Yes.
They are going to come home. Should they get infected in the school environment, our fallback position is ensuring that the parents are protected.
Yes.
And in any case, the children will be asymptomatic. They may not be severely ill. Many of them will be asymptomatic. So, for this reason, vaccinating elderly persons is part of our strategy for safe school opening.
I see.
And therefore, we appeal to LC1s, we appeal to village health teams, we appeal to health workers to ensure that proper targeting is done to protect our older generation, so that the mortalities, the deaths arising out of this outbreak will be minimized, and we will degrade this COVID to a common flu level.
We look forward to that point in time, and I'm sure it's just around the corner. As long as you and I do our part, if you're eligible for the vaccination, please go and get that jab and continue protecting yourself by wearing your mask, sanitizing, and avoiding crowds, and keep that social distance. I must tell you that our strategies are working, because our positivity rates have actually dropped. I don't know the latest, Dr. Juwale should be knowing.
It's 3.5.
Yes,
Yeah.
3.5. And remember, the president promised to open us up if it dropped significantly, and I think we are doing well. So kudos to everyone that is doing their part in kicking COVID out and getting us back on the road. So we thank you very much. I'm sure the Director General of Health Services has a parting shot for us. How are we doing in this battle, and what are we going to do to even win more?
Thank you, Joseph. Let me continue from where you stopped about the dropping positivity rate. That's a good sign, but the important thing is that we need to struggle to keep it there.
Yeah.
Because now people are getting excited after getting out of the lockdown. We are still seeing people crowding again.
Yeah.
We are seeing, as soon as the people came out of lockdown, they were disciplined, they were cooperating, they were emphasizing the SOPs. But people forget so quickly, and we are seeing people now sliding backwards, and therefore we may not maintain that 3.5. So my appeal to everybody is, let's maintain the SOPs. Please go and get vaccinated, and make sure that you take all your 2 doses. If you are taking the dose which requires 2 doses, complete your vaccination. Because we have friends, we have colleagues who have taken that vaccine and they have got sick, but they kept working, they kept with mild conditions, and they don't progress to severe and critical conditions.
Correct.
We have even been monitoring in our hospitals, treatment units, and we wanted to monitor and see of those who end up in high dependency
ICU
units and ICU. Do we have any cases who have been vaccinated? But the results we get is that we have not got cases who were vaccinated who end up with those critical conditions. So I really urge you to take your vaccine. The vaccines are safe, and the vaccines save us from severe disease.
Thank you. And in fact, the panel here is all vaccinated. If you wish to look at our certificates, we would gladly provide them. We are well. And be sure that in case you get any problem that may be vaccine related, the healthcare teams are really on high alert. In fact, we are looking out for anything. Please notify us, but we are ready to actually help you to live a good life after vaccination. And thank you to everyone that's gotten vaccinated. And if you're eligible, please be on that line. I'm glad I've been to many centers and I've actually seen people lining up for the vaccine as early as 6:30, like they are going to vote. We are seeing the lines coming in. Please keep social distance as you're doing that, but that is good, and we hope that the year that comes after this will actually be much brighter, and we shall be more free. We thank you for the victory that we have had already, and it is thanks to your efforts. It has been the DocTalk Show, your reliable source of information. Be sure to join us next Thursday for the same.
The DocTalk Show.
Bueno, yaba no mojo, yaba no wishi. I don't know. If it is a boy, I'm going to be calling Hakatabas. The garo ret nyana naza kumani mig. Otio, can't take anything crave. Ay. Riama katutumto. Ay. That's one that I'm with you. What's your? You have to look again. Sleep like a baby at home. Yeah. Thank you.
Katoto. Hold on. What about immunization?
No. Nga. Immunization bossy. Entuzaku chikoro wanyi.
Katoto, your son is a citizen of Uganda now. Atogo no mwana witu. Our government has assured that all these essential vaccines, they are free. To us.
You mean immunization is free?
Yes. So we have made sure that there are several health center units where you can take Katabazi and he gets essential vaccines. Before Katabazi reaches the age of 13, he will need to receive immunity against polio.
Polio? Whooping cough.
Tetanus, measles.
Yamawe, measles,
hepatitis, influenza. No. The government will even support you by giving you free mosquito nets to help fight against malaria.
Umwana kazarerwa.
Yes.
Amurere maura, down the corner. Yeah, yatunga immunization.